For part one of our fourth interview, Dr. Rebecca Flyckt chats with Dr. Togas Tulandi. Sit back, grab a cup of coffee, and enjoy what we think are valuable lessons about our history, sparking innovation, and newer surgical applications of reproductive surgery.
Hi, good afternoon. I'm here with Dr. Tulandi. As many of you probably know, Dr. Tulandi is professor and chair of the Department of OBGYN. He's also Milton Leong Chair in Reproductive Medicine at McGill University. Besides his medical degrees, he has a Master's of Science in Healthcare Management from Harvard University. He's authored over 400 articles, 60 book chapters, and 14 books. He's past president of our Society for Reproductive Surgeons, the Canadian Fertility and Andrology Society, and the Fellowship Board of the American Association for Gynecologic Laparoscopists, the AAGL. He's internationally known for reproductive and minimally invasive gynecologic surgery, and he is editor-in-chief for the Journal of Obstetrics and Gynecology Canada. Dr. Tulandi is a recipient of many awards, including the Award of Excellence in Reproductive Medicine and the Society of Reproductive Surgeons Distinguished Surgeon Award. Dr. Tulandi is routinely listed as one of the best doctors in Canada, and I think many of us in the United States would agree at home here as well. So it's my pleasure to be interviewing Dr. Tulandi for our series on surgical legends. Dr. Tulandi, I always think of you as part of my surgical family tree. I don't know if you know this, but we're connected through Dr. Falcone. I know you trained him in Canada, and then I spent many years working with him as a fellow and staff at Cleveland Clinic. So I think we share a little bit distanced relationship, but we kind of come from the same tree. So that's part of the reason that I was excited to be talking with you today.
Thank you.
Yeah, well, so welcome. So I don't know if you can see on the screen, we asked you to send us some younger pictures of yourself, but it looks like we're looking in a mirror. You haven't changed a day.
Well, maybe you need new glasses.
So share with us, what are these three pictures?
Well, I think the middle one is when I was a student. And then the right-hand side is when I was a junior staff. And the left-hand side is I was with Dr. Isaacson and D'Oliveira in one of the meetings. I can't remember where, but certainly it looks like it's nice and sunny.
You seem to be having a good time.
It seems like we work very hard.
The middle picture is when you were a student where?
I was a student in Indonesia and then at McGill.
Well, that kind of leads me into the first question. We would love to know just a little bit about you, your background, your family, and kind of what got you to here.
Well, I have a wife who is a family physician, a son, also a family physician, and a daughter who is a lawyer. And we just have, I think we have two brunette granddaughters, 3 and 1 years old.
Oh, how fun. Those are great ages. What brought you to medicine?
Good question, actually. I think it came by default. I really like to look after patients, to care of patients. And nobody in my family was a doctor. My brother was a pharmacist in LA. I have a sister, my late sister was in Denver, and we have a whole bunch of cousins and nieces in California and in New Jersey. So I'm the only one in Canada. They say, well, you're there freezing your butt. So, but I'm here.
So you're the black sheep.
That's it.
How long have you been working in reproductive surgery?
Oh, I think it's over 30 years. I started when, I was a fellow and then carry on. And that's, I enjoy doing this.
And was this always your passion?
My passion is surgery. In fact, I applied for surgical residency before. I got it, but the chief resident said you should become a gynecologist rather than a surgeon. So I followed him.
What made him think that you should be a gynecologist?
I don't know, actually. And then I look after his daughter. Actually, I'm operating her tomorrow.
And this was all in Canada, correct?
This is all in Canada, correct.
And were they very accepting of a surgical presence within gynecology when you started out?
No, I think, well, at that time, infertility was not very popular. I think I was one of the first fellows. It was under Dr. Brian Little, who was the chair in Case Western before he became the chair at McGill.
Oh, interesting.
It was not very popular at that time.
Did you feel it was an uphill battle for you too?
Well, I think I was one of the first, so a lot of people came to me for infertility and also for surgery. And then, I did it by laparoscopy, so we got busy just by doing that.
Share with us what you can about the early days of laparoscopy. There's so much that we take for granted now.
Yeah, it's very interesting, and we used. I think we were lucky because we have been doing laparoscopy before the surgeon, tumor ligation, this and that. So we just expanded. Well, at that time the tools were poor, so we expanded to become laparoscopic surgery, and I think with Dr. Falcone, we did the first hysterectomy by laparoscopy. It was fun, but the instruments were crude at that time, and we got better. Instruments got better, technology got better.
Yeah, he describes it as laparoscopy by candlelight. Like, what did your setup look like then?
Well, I won't go to candlelight, but the setup was fine. I think when we first started, we were still looking on the lens, but it didn't take long. And then we started to go to a video camera, and Dr. Nezat called it video laparoscopy. Mm-hmm. And so I think we were kind of fast in doing that. So in a 1 or 2 years, we were doing video laparoscopy.
How long did you keep the patient in the hospital after that first laparoscopic hysterectomy?
Oh, laparoscopic hysterectomy, we kept overnight. Mm-hmm. Just overnight. Even now, but now we send them home same day.
Yeah, for sure. Interesting. Well, you must have overseen a massive evolution in the field from the first days of laparoscopy till now. What do you think is the biggest change?
I think the biggest change is, I think surgeons are getting better. They're doing more invasive procedure, like endometriosis stage 4, colorectal rectal resection for endometriosis. We have a gynecology surgeon. He does colon resection here. He does urethral repair of urethral injury himself. He does everything, and he's a surgeon. He's a surgeon from France, and wow. He is a very good surgeon.
Who trained you? And we all have our mentors. Who were your mentors?
I think I started by myself. I trained myself, and basically we applied laparotomy technique to laparoscopy. And I look up at Victor Gomel, although I've never worked under him, but he was one of the first doing that. He was, I think, a generation ahead of me.
And I think that's still our goal, right? Like with my trainees, I often say, we don't want to sell anyone short by doing a minimally invasive procedure. They need to have all the benefits of an open procedure just done laparoscopically. So I think that is still very much our theme. Do you agree?
Oh yeah, I think we should not cut corners by laparoscopy. We should do exactly the same like we normally do by laparotomy. Just apply it to laparoscopy. Yeah. Including the sutures, including for silk glass. I use Mercilane tape. Some people use suture. Yeah. Because it's easier.
So it sounds like you kind of found your own way in these early days. Who was part of your surgical cohort? I certainly have mine, but who were people that you compared notes with as you were finding your way?
Well, I think I talk to Victor Gomel often. But
you'll be
he
happy
was
to know
doing about
he's also being featured in the Surgical Legends series. So you'll be in good company with him.
Yeah, well, I spoke to Victor, and he does it by laparotomy then, but I do it by laparoscopy. And then we have Dr. Falcone, who is just a few years before me, after me actually, a few years after me. And my mentor is Rob McGinnis, who was at the Mass General until he retired with John Pedrosa a few years back. Yeah.
Early in your career, what was the element of reproductive surgery that you were the most curious about? Was it the tubes? Was it the uterus, the ovary, implantation? Like, what was your focus early on?
The tubes. In fact, I think I was lucky because the chief of the department allowed me to use laser. So we managed to do a randomized study, actually, comparing the use of laser versus non-laser for hydrosalpinx. And we found there's no difference. I presented the paper in one of the meetings, and I almost got killed because they say a good surgeon should know how to use laser properly, and the results should be better than without laser. And I was discouraged, and people told me not to publish it because you will get killed. On the paper, I published anyway because it was a randomized study. It took me over a year to do it. We published it, and turned out that it was actually it was quoted over and over.
Yeah, I certainly associate you with tubal surgery. I actually was thinking about it. I was in the OR today doing a linear salpingostomy with our first year fellow, and she did a fantastic job for this ectopic, but she had never done one in all of her residency, never seen one. And we were talking about the fact that there's this huge debate about what the role of tubal surgery is going to be in this era of assisted reproduction. And, it worries me to think that the art of tubal surgery may be lost over time, especially as things move to MIGS and, fewer REI fellows are getting the surgical training they need. What would you say about that, having seen progress over the last several decades?
Well, it's true because the number of cases for tubal surgery has been getting much lower. Patient has hydrosalpinx before IVF. Now we remove the hydrosalpinx rather than tuboplasty. Tubal anastomosis, I rarely do it now. I used to do it almost every week. We rarely do it.
My absolute favorite surgeries. That's what made me fall in love with REI.
Yeah, we rarely do it. At the most, once every 2-3 months, I do tubal anastomosis. And so everything is going down in terms of reconstructive surgery. But we do other things to increase the IVF success rate.
So what do you see the future role? I mean, there will be people out there listening to this who have passions like yours or like mine of, spending their days in the OR in addition to doing IVF. What would you say to someone like that coming through now?
You mean REI or?
Yeah, REI.
I think tubal surgery, tubal anastomosis still has a very good success rate. Patients who do not want IVF or cannot afford IVF, I think we still say tubal surgery, tubal anastomosis is still good. We'll give her a good result. Of course, we have to talk to them about ectopic pregnancy, this and that.
Do you do your anastomosis laparoscopically or robotically?
No, actually, I don't. I used robot for 2 years for hysterectomy and myomectomy, and then I stopped. I think number one, I think the docking time at that time was kind of long, and I can do more big cases in a day compared to the same cases using robot. So I don't use the robot, but I do everything by laparoscopy. I don't do laparotomy at all. If patients want laparotomy, I send them elsewhere.
And I know you've been incredibly active in your research career. What are some of the things that you're researching now, and why have you chosen those things?
Well, I think now is endometriosis. I'm running a department, and we have a PhD who is his research is also involving endometriosis. In fact, we are looking at Wnt signaling in endometriosis, and well, we have high expectation. Maybe, hopefully, we can find the etiology of endometriosis. I don't think so. We also
I'd love to see that in my lifetime. That would be great.
We are also involved in studies looking at markers in the endometrium and in the blood, and hopefully we can diagnose endometriosis without surgery in the future. There are so many markers now, we don't know which is which, but we are looking at that, and we have several epidemiological studies on endometriosis.
Do you think that'll eventually put reproductive endosurgeons out of business?
I don't think so.
I don't think so either.
I don't think so.